Thank you so much for joining us for the Cardiology Gram Rounds, for those of you in the room as well as those online. I have the pleasure of introducing Dr. Graham Bevan today in place of his mentor, Babak Nazar, who is out of town currently. So Graham grew up in Seattle, and an interesting fact is that his parents were immunology professors. He then moved to Minnesota for college. Between college and medical school, he did some interesting things. He acted as a medical scribe, but what a lot of you probably don't know is he also served as a ranch hand in Nevada. I'm sure he has great stories from that. He then went to the University of Rochester for medical school, where he met his wife, Becca, and then they couples matched at Case Western, where he was in the T32 program studying ambient air pollution and cardiovascular disease. And because partly from his research, he decided he wanted better air quality. And for that reason, he decided to move to Seattle to join us here. So Graham has shown tremendous acumen for academic pursuits with 17 peer-reviewed publications to date. What was really striking to me when looking through his CV is that he was the first author on the majority of these publications, which really underscores his leadership and the initiative. He started his research projects with Babak from scratch, including forming his own hypotheses and aims, with a plan for a multi-year research arc, and he's going to stay here as an EP fellow next year to really continue on his research. So I think one of the interesting things is that we think we see a lot of cardiac sarcoid. I'm sure you think you've seen some cases yourself. For example, a patient comes in with LV dysfunction as well as arrhythmias. The question is, does the patient actually have sarcoid? So I think we make this diagnosis oftentimes on the basis of PET imaging being positive. It turns out that a lot of these cases probably are not sarcoid. And the question is, when it's not sarcoid, what is it? So today, Graham will be providing us some insights onto what these other cases may be. He's going to explain to us how such things as genetic cardiomyopathies can also lead to FDG-avidity. Interestingly, his work also aligns with what his parents did in terms of there's some focus on immune function as well as inflammation. So please join me in welcoming Dr. Bevan today.
Thank you. That was very kind. Thank you. Where's the slide advancer? Okay. All right. Thanks again for that introduction. I just want to highlight to my mentors here, Babak Nazar and April Stempino-Otero, who are both on well-deserved vacations. Unfortunately, I have no disclosures yet. And my objectives. So I'm going to describe the utility of diagnostic testing and the workup of ischemic cardiomyopathy and complexity of its interpretation. Yeah, hearing anything, turn up. Go ahead. I'm doing it backwards. Everyone's waiting. Well, maybe you should do it. All right, you do it. I can't drive backwards. There we go. That was incredible. So I'm going to describe the utility of diagnostic testing and the workup of non-ischemic cardiomyopathy and the complexity of this interpretation. Next, I want to talk about the mechanism of FDG PET and understand how this might explain inflammatory or metabolic changes in cardiomyopathy. And then finally, I want to talk about ongoing research efforts here to define prevalence and mechanism of FDG-avidity in genetic cardiomyopathies. And this is something that I've been working on for past half year to a year or so, and will plan to continue on during my electrophysiology fellowship starting in July.
You're on designer mode?
Yeah. I don't know where it's.
Where's the slide announcer? It's so he's not submitted designer mode for some reason. I won't switch. Sorry for the technical difficulties.
Did you?
Yeah. Yeah, I think he's in like the slide view. I think that's the sort of shoot around once I want switch over.
Great.
You can use the arrows now.
Arrows, okay. Sorry about that. Wonderful. Okay, so I'm going to whet the appetite a little bit with a case presentation here. This is a presentation of a 60-year-old who presented with non-ischemic cardiomyopathy. And when he originally presented, he had quite significantly reduced left ventricular ejection fraction at 24% with some regional wall motion abnormalities. When he initially presented, his NYHA class was 3. He had a CPET of 15, so quite advanced at that point. Had a rhythm monitor, which showed a couple of episodes of not particularly fast, non-sustained ventricular tachycardia, but he had no known sort of endocrine, rheumatologic, or pulmonary disease. Okay, so I'm going to just briefly introduce that this is the 2022 ACC-AHA diagnostic sort of algorithm for heart failure. And I only want to mention here that it does not really go into great detail as to who should receive additional testing. So you can see that after sort of an initial clinical assessment, some labs, and an echocardiogram to classify the type of heart failure, they recommend at the bottom evaluate for precipitating factors and mention some causes, which includes infiltrative disease, such as sarcoidosis, but does not explain exactly which patients should undergo this additional testing. Our patient, because they're at the University of Washington, did end up going a very thorough workup and had a cardiac MRI, which showed focal near transmural subendocardial delayed enhancement, and that this could be due to a pretty broad differential of embolic infarct, cryomyocarditis, or sarcoidosis. So quite a broad differential for this patient, but one of which was sarcoidosis. And I want to talk about how the diagnosis of sarcoidosis is made briefly, but I also want to underscore that this is likely a very underdiagnosed sort of entity. Clinically apparent cardiac sarcoidosis comprises 5% of the systemic sarcoidosis population, but on autopsy studies, roughly 20 to 30% of patients have cardiac sarcoidosis on autopsy. So clearly it's an underdiagnosed phenomenon, and it's important because it's also the most common cause of death from sarcoidosis, accounting for roughly 75% of the mortality. And unfortunately, as most of us here know, the sensitivity of a non-voltage gated biopsy is actually quite low. It's only roughly 20 to 30%. And so it's a very difficult entity to sort of diagnose. And there are other sort of lines of research that suggests that we're underdiagnosing this as well, and that it may be more common than we really expect. This is a study from Helsinki, from a group in Helsinki, looking at all patients between 18 to 55 that had a pacemaker implantation. And you can see here that they had a total of 212 patients. And of these patients, 19% of these patients actually had cardiac sarcoidosis. So all patients under 55, it's actually quite common, about 1 in 5. And there are about 6% of these patients had giant cell myocarditis as well. So both of those two entities can be common causes of conduction disease in relatively young adults. This number increases even to 25% when you account for sort of known causes of AV blocks, such as surgical causes or congenital heart disease. So very common. And it's important here because when they follow these patients over a total of 100 months for some of these patients, 39% of those with cardiac sarcoidosis or giant cell myocarditis ended up having a very serious cardiac event, such as VTVF, death, or transplant. So these patients need to be diagnosed early. And I think most of us clinically have at least seen some patients who were young, who had a pacemaker implanted, who did not undergo such a thorough workup for sarcoidosis. And there are other lines of inquiry as well. This is actually published by Rod Tung here in 2016. And this was a prospective study. They enrolled just 103 patients looking for who were referred for ventricular arrhythmia management. And about half of these patients had an abnormal PET scan. And then among the entire cohort, almost 17% ended up having a biopsy that was positive for sarcoidosis. And this Diagnosis tended to be made from positive lymph nodes on biopsies. So that was sort of the most common way, with only 3 of 10 patients who had an endomyocardial biopsy having a positive biopsy. So very common even in just routine cases like non-ischemic cardiomyopathy, relatively routine non-ischemic cardiomyopathy with ventricular tachycardia. And it's because cardiac sarcoidosis is so difficult to diagnose that the Japanese Ministry of Health and Welfare created an algorithm which allows you to diagnose cardiac sarcoidosis clinically without the presence of tissue biopsy. And so on the top screen, it's kind of cut off there, but you can see that on the right side, these are patients without a histologic diagnosis of extracardiac sarcoidosis. And cardiac sarcoidosis can be diagnosed clinically by utilizing some criteria. These criteria include LGE on CMR. Patient had this, cardiac uptake on PET, and low EF, and then significant arrhythmias like ventricular tachycardia or conduction disease, as well as any wall abnormalities, which include thickness or thinness of any of the myocardial segments looked at. So some of those are a little bit sort of squishier than others, and this diagnosis can be very difficult to make. And I want to highlight, so our patient did end up undergoing a FDG PET scan, sort of on this continued track to try to make a diagnosis for this patient. And before I really launch into the results of this patient's FDG PET, I want to describe a little bit about how FDG PETs work. And that involves normal myocardial metabolism, since FDG PET is really a test of myocardial metabolism. And this is a paper that I'm going to reference in much greater detail later. It's actually sort of a busy slide now that I'm seeing it here on a big screen. But the authors looked at arteriovenous gradients from the radial artery, coronary sinus, and femoral vein. And they looked at carbon uptake by these different muscle beds, namely the femoral muscle, as well as the myocardium. And you can see on the right in that big sort of bar graph that in the fasting state, the myocardium is almost exclusively reliant on free fatty acid oxidation for its energy production, whereas skeletal muscle still utilizes a lot of glucose. And FDG PET takes advantage of this unique form of metabolism. And in the postprandial state, so while in the postprandial state, it can use up to 50% of energy can be derived from glucose. In the fasting state, there is increased free fatty oxidation, and it uses almost exclusively free fatty acid oxidation. So the way that FDG PET works is the FDG molecule, which is shown sort of on the bottom right there, which resembles very closely glucose, is taken up by GLUT transporters in the cell. And there it accumulates in the cytosol, where it can then be visualized. It does not go on for any further sort of metabolism in the mitochondria. And since in the fasting state, the myocardium does not utilize glucose, this is, or is assumed to not utilize glucose, this accumulation of FDG is felt to represent sort of inflammatory infiltrate, since inflammatory cells are still quite glucose avid, even in the fasting state. So that's sort of how FDG PET works. Those are the basic principles. And our patient does undergo one of these FDG PETs in a fasting state. And in usual, very cryptic language, I included this here because the fellows, including me, like to include a lot of different areas of inflammation. But you can see in the image below on the top row, those are the perfusion images. And in the apical area, there is some perfusion abnormality, which actually matches a little bit of FDG uptake in the bottom row. But the predominant area of FDG uptake is sort of in the basal lateral wall. And so this patient had a positive FDG PET for both perfusion abnormalities and for FDG, which was assumed at the time to represent cardiac inflammation. Okay, and the patient actually ended up undergoing a voltage-guided biopsy. Since there was still some uncertainty, the patient had no sort of hot lymph nodes or anything else to suggest really systemic cardiac sarcoidosis. And so they underwent a voltage-guided biopsy. And this is a test used to look for scar in the right ventricle prior to biopsy, and that can represent so that these areas of, so it's really looking for areas of lower voltage. And on the right picture, you can see the right ventricle, and any area that's sort of purple has normal voltage, and any area that's lower than that normal voltage is classified on this color-coded map as having lower voltage, and that's assumed to represent either inflammation, edema, or scar. And actually, there's a video here which I don't know that I can necessarily play, since I can't see the slide. Yeah, I'm not going to be able to play that. But the way that this works is that mapping catheter, which is sort of on the right-hand side of that image, is inserted into the right ventricle, and it measures sort of local electrograms and voltage at various points in the ventricle, and then categorizes those and sort of color codes those. And on the right picture here in the lower right-hand corner, we can see the 3 green dots represent those areas in which a biopsy was taken. The biopsy results just show focal interstitial fibrosis and cardiomyocyte hypertrophy, which is sort of boilerplate non-ischemic cardiomyopathy. And there's specifically mentions no evidence of inflammatory process and specifically no evidence of cardiac sarcoidosis. And so this patient, while they had a positive PET, did not have clear evidence on biopsy. We know that those sensitivities are imperfect. And as such, this patient was actually, and here's again, this Japanese Ministry of Health and Welfare diagnostic criteria. The patient didn't really quite meet criteria. You can see that although they had a reduced EF, positive PET, and an LGE on CMR, that they didn't quite meet the 4 of 5 criteria, but different interpretation of wall anatomy or even the development of an arrhythmia might change this diagnosis for this patient. But nevertheless, because there was some uncertainty, the patient actually underwent diagnostic testing or genetic testing, which was positive for a likely pathogenic variant in the titin gene, which was predicted to form a truncated titin protein at the I band. So this was deemed to potentially be the cause of this patient's cardiomyopathy. And though it's not the sort of explicit purpose of this talk, I want to talk a little bit about how genetic testing it can be useful clinically. I think most of us sort of understand that it can be helpful for family screening when testing probands for if you do propan testing, for instance, you can identify family members who may be at risk. But there are also other rationale to order genetic testing, including risk stratification. And there are some phenotypic differences between patients with different types of genetic variants. On the bottom here, I've displayed the 2022 ACC/AHA recommendations for who should undergo genetic testing. And they're also somewhat vague here. So obviously, they recommend testing in patients with first-degree relatives who have inherited cardiomyopathies. And then they just recommend on the bottom a 2A recommendation in select patients with non-ischemic cardiomyopathy referral for genetic counseling and testing is reasonable. So it's not clear exactly who should undergo this testing, but we know that there is some benefit. And genetic variants can come in a variety of different types of proteins in the cell, including cytoskeletal proteins, nuclear proteins, desmosomal proteins. And so many different sort of types of genotypes can produce a dilated cardiomyopathy. There is some evidence that it can help in risk stratification. And here is sort of a schematic to look at different types of genes and increasing risk of sudden cardiac death. And on the left, you can see lamin, which is much higher risk than many of the other variants for sudden cardiac death. But filament C, phospholammin, and many of the ARVC genes also have pretty significant risk. On the bottom, I've included some calculators which actually utilize these specific pathogenic variants to try to estimate sudden cardiac death risk. This was a paper published from the Netherlands, just looking at 487 patients were referred for non-ischemic cardiomyopathy with the finding that 37% of these patients had a pathogenic variant. And when they divided these patients by pathogenic variant or non-pathogenic variant, there was numerically a different level of sudden cardiac death or heart failure in patients who had pathogenic variants, but it did not reach significance. However, in the bottom right-hand corner, if you can see, they separated these patients by type of variant, including desmosomal and lamin. And you can see that there's clearly sort of a qualitatively much higher risk of sudden cardiac death for these two types of when these two types of genes are involved. And on the left hand, we can see another survival curve. This is post-VT ablation outcomes. And you can see that patients who do not have any pathogenic variants have a much higher likelihood of being free from VT or death than in those patients with non-lamin pathogenic variants, and worst of all, sort of pathogenic lamin variants. On the right-hand side, this is a paper published last week by Katja Zeppenfeld, looking at different phenotypic differences between different genotypes. And quite interestingly, you can see that lamin and titin tend to involve more LGE on cardiac MRI in the basal septum, as does hypertrophic cardiomyopathy. Whereas you can see filament C tends to involve more of the basal lateral wall. And this is important actually because it affects different sort of access and outcomes for VT ablations going forward. So you can see that there are some phenotypic differences that can influence sort of outcomes of various treatment strategies. Whatever the reasons are for genetic testing, it's clear that we're not using it at any great rate. This is a retrospective study of outpatient records and insurance claims from 2017 to 2021, which included some small community practices, utilized ICD codes. But the inclusion of these small practices changes sort of the prevalence of how often this is ordered, because many of the other prior studies actually just looked at academic centers, multi-center academic centers. But you can see that even for sort of more established indications for ordering genetic testing like hypertrophic cardiomyopathy or long QT syndrome, we're still getting this at less than 5%. And so it's probably underutilized overall. Okay, so back to our patient. We've got a positive PET, and we have to ask ourselves sort of what does that actually mean for our patient? They have genetic testing. Does the positive, or they have positive genetics, does the positive FDG PET, is it just sort of a false positive? Does it have any specific meaning for this patient? And there isn't a whole lot of data on this, but Blankstein's group in 2014 published a paper that I think our patient sort of would have fit kind of nicely into, which was a prospective look at 118 patients referred for FDG PET. And what they found is, again, that many of these patients had abnormal PET, 71 of 118. And 38 of these patients had a sarcoidosis diagnosis. So the majority of these patients did not have cardiac sarcoidosis. And in fact, 41 of these patients, including the study, had an abnormal PET, but did not have sarcoid. So I think that would sort of include our patient. And although these patients weren't genotyped, I'm willing to bet that if they went back and genotyped everybody, some of these patients probably would be positive for genetic cardiomyopathy. And you can see in the bottom left-hand corner, the survival curves. Patients with abnormal perfusion and abnormal FDG, just like our patient, had clearly worse survival, which was actually, this was death and VT-free survival. And so it's clear that I think there's evidence to suggest that FDG PET still provides important prognostic value, even for our patients that don't have clear sarcoidosis and don't have any sort of clear inflammation, at least on biopsy. On the right-hand side, they controlled for a variety of factors, including a diagnosis of sarcoidosis in a multivariable model, and FDG PET, especially abnormal metabolism and abnormal perfusion, is still an important predictor of bad outcomes. Okay, so this brings us back to our patient, in which there is somewhat of a diagnostic dilemma. I think we have two different options here. One is that there is some active inflammation we didn't capture on biopsy. There's active inflammation in this patient with genetic cardiomyopathy. And the other is that because FDG PET is really a test of metabolism, that we're really picking up metabolic changes. And so that there's a metabolic switch, which may account for, which may be present in genetic cardiomyopathy or may account for progressive heart failure. And I want to talk about some of the background evidence for each one of these, or for both of these different hypotheses, and why they may or may not be true. Okay. And actually, Dr. Ferris is here, so there's a direct reference to Dr. Ferris, but there is evidence that there is inflammatory infiltrate in just non-ischemic cardiomyopathy. And you can see here, these are CD68 positive cells, just on the lower left-hand corner, that are present in patients with non-ischemic cardiomyopathy. So I want to emphasize that this is not to suggest that inflammation has no role in non-ischemic cardiomyopathy. The real question is whether or not it has a role in genetic cardiomyopathies. And there is some evidence already, of course, that there is inflammation in genetic cardiomyopathies. I think most of us recognize that ARVC has potentially some inflammatory component. And when they look at autopsy studies, about a third to two-thirds of patients on autopsy who have ARVC diagnosed pre-mortem end up having some inflammatory infiltrate. Of course, the interpretation in the post-mortem setting can be a little challenging, but nevertheless, there is some inflammatory infiltrate for these patients. And interestingly, many patients with ARVC also have circulating autoantibodies to important proteins, and these include anti-DSG2, anti-HART, anti-intercalated disc. And it's thought that sort of the exposure of some of these desmosomal proteins to the immune system may provoke the development of true ARVC. And at the bottom here, I've just sort of included one of the major models that is now sort of helpful for thinking about pathogenesis of ARVC, which is that patients with a pathogenic variant who have some adverse environmental stimulus, which can include excess exercise or an infectious immune agent, go on to develop myocardial damage and necrosis, and then develop sort of the pathognomonic extensive fibrosis that we see with ARVC. There's also evidence of some overlap in myocarditis. If you look at patients in this group, looked at 336 patients, one cohort was in London, one was in the Netherlands, who were diagnosed with acute myocarditis. These patients were diagnosed either by Lake Louise cardiac MRI criteria or by biopsy. And then they were prospectively genotyped. And you can see that 8% of these patients who presented with acute myocarditis had a pathogenic variant versus less than 1% of the sort of healthy control population they included. And so there's clearly some overlap between myocarditis and pathogenic variants. And it's thought that there may be a two-hit hypothesis and that there is the presence of a genetic abnormality and, with the presence of, an infectious agent, they go on to develop a true cardiomyopathy. And then finally, there's this very interesting paper that was published relatively recently out of Italy, which selected patients who had some inflammatory infiltrate on a biopsy, as well as pathogenic variants. And they included 25 of these patients. It's unclear exactly what prevalence they used. And actually, Babak and I sent a letter to the editor to ask a few questions about this. And they replied that a formal myocarditis diagnosis was actually only in 4 of 25 of these patients. And so it's not clear the extent to which inflammation was actually involved. But nevertheless, they treated some of these patients with immunomodulatory therapy, and they found a non-randomized difference in myocardial inflammation clearance at repeat biopsies. So they biopsied these patients multiple times in patients who were immunosuppressed than in those who were not. They also showed clinically there was a reduction in PVC burden and troponin. So this is sort of the first look at treating patients actually who have inflammation and genetic cardiomyopathy, with a finding that there may be some clinical evidence, though obviously this would really need to be followed up with a sort of a more stringent randomized control trial before making any formal recommendations. And it still remains a little bit unclear about what percentage of patients actually have some of this inflammatory infiltrate or to what extent. Okay, so back to our diagnostic dilemma. The hypothesis that it's inflammation in genetic cardiomyopathy, well, there is some underlying evidence, including evidence in patients with ARVC. The overlap in patients with myocarditis and pathogenic variants. And then finally, there is this recent paper showing that maybe immunomodulation in patients with genetic cardiomyopathy could be helpful in clearance and with some sort of secondary clinical characteristics. But I want to transition and talk about the second hypothesis, which is that there are myocardial metabolic changes related to progressive heart failure and genetic cardiomyopathy. And I want to reference back to our discussion about how FDG-PET works, only to say that we already sort of know that FDG-PET at its core is really a test of metabolism, and it's not a direct test of inflammation. And actually, there are a lot of pathogenic there's a lot of pathology that is already associated with abnormal PETs or just abnormal glycolysis. And this is an example of a PET MRI. And on the right-hand side, you can see just the MRI. And you can see that there's a transmural infarct, so transmural LGE in the septum. And then overlaid in the center image is a PET scan. And you can see that there's heavy sort of FDG-avidity to the side of that large infarct. And that could be ischemic, an area that's ischemic because ischemic myocardium tends to be more glucose avid. But it could also just be activated fibroblasts laying down more scar. And this is actually a viability test. So this is a test that we already use, which is testing metabolism in ischemic heart disease. But there are other situations in which glycolysis is clearly altered, including in the process of hypertrophy. And when you look at mouse models of hypertrophy, it seems there's sort of evidence to suggest that the process of hypertrophy itself is reliant on increased glycolysis. And we'll see how that may play out clinically momentarily. And in the bottom, it's also clear that there's dysregulation of glycolysis in the failing heart. And on the right-hand side, you can see a figure taken from a paper published in 2016 looking at non-diseased hearts pre-LVAD and post-LVAD. And there is significant differences between different glucose metabolites in various states of heart failure. And it's thought potentially that, sort of a strong hypothesis for the development of heart failure, which is a transition to a fetal form myosin, beta myosin, which has lower contractility, that beta myosin may be more glucose dependent than alpha myosin. And so this gets back to sort of a fundamental principle of heart failure itself. Going back to the hypertrophy sort of aspect of this, which may be glucose dependent. This is a paper published in Japan in 2017, which takes a clinical look at this. And they looked at 30 patients with hypertrophic cardiomyopathy undergoing FDG PET. And interestingly, all of these patients had some degree of FDG avidity. It's not a condition that we normally associate with active inflammation, but you can see that it also differed by the area of hypertrophy. On the top right-hand corner, you can see non-obstructive hypertrophic cardiomyopathy or left ventricular outflow tract obstruction, mid-ventricular obstruction, and dilated cardiomyopathy. Each of these areas had had sort of a different pattern of FDG avidity. For instance, left ventricular outflow tract obstruction tended to involve more basal septal kind of FDG avidity. And so it seemed to kind of correlate with the areas that we would expect more hypertrophy. And interestingly, when these patients underwent septal reduction therapy, there was a decrease in FDG avidity. So it's a little bit, it seems less likely that this process was all related to inflammation, and it may be related itself to hypertrophy. And next, referencing a paper published by Babak, and this was before he came to University of Washington when he was at OHSU. He looked at 110 patients referred to him for cardiac sarcoidosis, and specifically found 16 patients with isolated cardiac sarcoidosis. He recommended genetic testing in all of these patients. 14 of them underwent genetic testing, and 5 of these patients, so a hefty number, had pathogenic variants. So roughly a third of these patients actually ended up having pathogenic variants. 2 of them were lamin, others were in sarcomeric proteins. Not traditionally thought to be, sort of inflammatory disease. And when they took a closer look at the patients with isolated cardiac sarcoidosis, you can see that a lot of these patients have second or third degree heart block, VT-VF, things that might have actually gotten them a Japanese Ministry of Health and Welfare diagnosis of isolated cardiac sarcoidosis. And 8 of the patients actually ended up undergoing cardiac biopsy, none of which had any evidence of sarcoidosis on them. Interestingly, 3 of these patients had long-standing immunosuppression. With no sort of clinical improvement or no improvement even in FDG avidity, and so he's able to stop immunosuppression on this, suggesting that genetic testing could actually be useful in the diagnosis of isolated cardiac sarcoidosis, since ruling it out may be helpful. And there are other publications out there that have looked more specifically at biopsy data from patients with genetic testing. And this is just a patient cohort of 16 patients with ARVC who underwent PET for device infection. And 7 of 16 had some FDG-avidity. Most of these patients did not have, and of the 3 of 7 patients who had FDG-avidity, of the 7 patients who had FDG-avidity, 3 actually ended up having pathogenic variants, and none of these 3 patients had any inflammatory infiltrate on biopsy. And similarly, another paper published more recently in 2022, looking at 17 patients with a more diverse array of different types of genetic variants, showed that 10 of these patients, the majority, had FDG-avidity, and 5 of 10 of these patients had a myocarditis presentation, and 2 of these patients that were biopsied had no evidence of inflammation. So, and if you take a sort of a look at all the papers that have done genetic testing and biopsy, you can see that actually none of them have really identified, with the exception of a more recent paper I mentioned earlier by Pareto, none of them have really identified inflammation or inflammatory changes. So this is a total of 36 patients, so not too many out there in the published world, with 9 different genes, and 11 of these patients underwent biopsy with 0 positive inflammation. So on the side of myocardial metabolic changes related to progressive heart failure and genetic cardiomyopathy, sort of back to our patient about is it metabolic switch, or is it inflammation in patients who have genetic cardiomyopathy? There's sort of evidence to suggest that metabolism may be the important factor here, including changes in glycolysis, which are associated with a number of different pathologies, including just heart failure itself. FDG-avidity with genetic variants that are not typically associated or not thought to be inflammatory themselves. And then finally, just the sort of a notable absence of inflammation on a number of different studies that have looked at patients with genetic cardiomyopathies who have had biopsy. Okay. So switching gears now, it is sort of on this background that we formed a hypothesis, which is that FDG-avidity and genetic cardiomyopathy represents a metabolic shift and not an inflammatory one. And it represents a metabolic shift from fatty acid oxidation to glucose metabolism rather than inflammation. So there is some kind of difference in metabolic process, which explains the FDG-avidity in patients with genetic cardiomyopathy. And we also hypothesized that FDG-avidity on PET may indicate genetic cardiomyopathy in the absence of extra cardiac sarcoidosis. So maybe this is even a predictor of genetic cardiomyopathy. These were our hypotheses at the outset, and we had a couple of different aims here. One is to look at the prevalence and predictors of FDG-avidity in genetic cardiomyopathies. And then 2 is to determine any metabolic or inflammatory associations through sort of deep phenotyping and metabolomics and tissue phenotyping. We're going to go into how we're going to look at these momentarily, but we have 3 different sort of studies that are kind of going on simultaneously. One is just a retrospective review of genotype and FDG-avidity at the University of Washington. And our second study is looking at an LVAD and transplant biorepository to look at differences in the tissue of patients with FDG-avidity and without FDG-avidity. And then finally, to look at the prevalence and mechanism of FDG-avidity and genetic cardiomyopathy for patients referred to the EP lab for cardiac arrhythmia and non-ischemic cardiomyopathy. Okay, so we're going to talk about each of these. And our first is looking at the association of FDG-avidity and genetic variants. And this is the retrospective review. We looked at visits at the University of Washington, so almost 4,000 cardiogenetic visits, 1,500 FDG PET scans, combined those, and found a total of 112 patients who had both genetic testing and FDG PET scans at the University of Washington. And what we found is that when you break this down, 21 of these patients, so 19% of the patients who had a PET or were referred for an FDG PET ultimately had pathogenic variants. Most commonly, these patients had VUSs, which is sort of typical of genetic testing for dilated cardiomyopathy. And then 38% of these patients had just a benign variant or no notable variant at all. And so when you break this down, we see that 20% of FDG-avid patients 20% of patients who have a genetic cardiomyopathy end up having, 20% who have FDG-avidity end up having a genetic cardiomyopathy. And if you look up here, we break this down by variant type. And you can see across the group, there's no real distinction between, there's no real increased likelihood of having a pathogenic variant in this cohort with having FDG-avidity. And so it didn't appear that there was an association with variant type and FDG-avidity. And these pathogenic variants occurred in sort of a variety of different proteins, including cytoskeletal, desmosomal, sarcomeric, and most commonly across the board was lamin, as many of us at University of Washington have experienced clinically. And we found FDG-avidity occurred in each one of these, so it seems sort of unrelated to the protein that was affected. So in summary, 20% of FDG-avid patients have a genetic cardiomyopathy, and 62% of genetic cardiomyopathy patients are FDG-avid, sort of vice versa. And so certainly having FDG-avidity does not suggest the patient does not have a genetic cardiomyopathy, but it also doesn't suggest the patient is more likely to have a pathogenic variant. And it's present in a diverse array of phenotypes, so that sort of variable, sort of somewhat independent of the gene that's been involved. We've got a number of next steps, including sort of looking at the performance of the Japanese Ministry of Health and Welfare sarcoidosis diagnostic criteria, looking at associations of outcomes, so sort of repeating that prior paper that was referenced by Blankstein to look at what are the outcomes for patients with genetic cardiomyopathy and FDG-avidity. And then look if there's any immunosuppression at what that may or may not do to clinical outcomes. So our second project, which is taken sort of the lion's share of my time, I guess, over this past half year to year, is primarily led with Babak as well as April here at University of Washington. And I also want to thank Shinlin, who's taken a lot of the tissue that we used here along with April. But we're doing a biorepository analysis of LVAD and transplant patients all the way from May 2017 to March 2023. And including only those patients with non-ischemic cardiomyopathy and PETs. We're excluding patients with congenital heart disease, redo transplant, or a problematic looking FDG PET. And in total, you can't see on the top, we looked at about 400 patients with non-ischemic cardiomyopathy who were included in the biorepository analysis, with a total of 252 patients with non-ischemic cardiomyopathy and 22 with mixed cardiomyopathy. Of note, the prevalence of genetic testing that had been done already on these patients is somewhat low. 17% of patients with non-ischemic cardiomyopathy who needed a heart transplant or LVAD had genetic testing. And not very many of these 252 patients actually had an FDG PET. But we did find a total of 36 of these patients with tissue who had both PET and some of them had genetic testing, but we obtained genetic testing on as many as we could for the remainder. This 36 group was divided into 23 patients with no known diagnosis of cardiac sarcoidosis, but had a PET, and then 13 patients with probable or suspected cardiac sarcoidosis, of which 5 of these patients really had confirmed cardiac sarcoidosis by biopsy and on the tissue that we actually have. And then 12 patients had a positive PET and 11 patients had a negative PET, so roughly equal looking. Overall, the results look somewhat similar to what Babak had previously published and look somewhat similar to our retrospective review, which is that about a third of these patients had pathogenic or likely pathogenic variant. And it didn't seem to favor FDG-avid or FDG-negative patients. So the 6 patients that we got genetic testing for who were FDG-negative, 50% of these patients had a positive variant. Notably, we did identify a couple of pathogenic variants on this study, and so families were notified, and we're going to be following that up later as well. So just to quickly summarize, so far what we've talked about, 17% of patients with transplants had genetic testing here at the University of Washington, and pathogenic variants are quite common amongst patients who were tested, but there didn't appear to be an association with FDG-avidity type. Next, we're going to be looking at a variety of different types of tools to try to understand whether or not inflammation is affecting the tissue that we have on hand for these patients. We're going to be using NanoString RNA-seq, which is actually a company that's based here in Seattle, to look at gene expression in affected myocardium. We're going to be doing quantitative immunohistochemistry. I don't know if Rashid is here, but he's already graciously volunteered to do all of that for us. He actually has not, but I'm volunteering him right now. We're going to be doing spatial transcriptomics as well, which allows us to look at gene expression by cell type while preserving the sort of tissue architecture to give us really an understanding of where that inflammation is occurring, if it's occurring amongst immune cells, the myocardium, or elsewhere. And we have some data here just for looking at, this is a NanoString, including just 4 of our patients. We're going to be expanding this number shortly. And you can see there's actually quite a bit of diversity in expression of these fibrotic and inflammatory genes here on the left. And so we have patients with FDG-avidity, and then one patient that had a negative PET, but that negative PET was done years ago, so probably will be ultimately excluded from our analysis. But you can see there's quite a bit of diversity here in the amount of inflammation. And actually, our second, the second patient from the top, the first patient who was positive, has a pathogenic myosin-binding protein C3 and seems to have quite a bit of inflammatory sort of gene expression present there. So it remains to be seen whether or not that'll be true across many of our patients, and whether or not there's a difference between patients who have a positive PET and negative PET. Moving on, we also looked at just expression and the amount of fibrosis. This is picroserous staining, and that's staining done on a section of a heart that's on the left there. And when we divided these patients into patients who had positive PETs and negative PETs, we can see that there is sort of a numeric difference in the amount of picroserous red positives area on the sample, but actually it wasn't significant. I think we're going to be able to increase the number of patients we have there and probably increase the power of what we're doing. But that's sort of an example of some of the quantitative immunohistochemistry that we're going to be doing. Okay. And finally, this is our prospective look at the prevalence and mechanism of FDG in genetic cardiomyopathies. And this is a study that we're going to be working on, I'm going to be working on more closely over the course of my EP fellowship, enrolling patients as we're taking them to the lab. Patients are going to be enrolled who have a non-ischemic cardiomyopathy and really an indication for FDG PET. So these are going to be patients with arrhythmias with non-ischemic cardiomyopathy. And we're going to get genetic testing and an FDG PET on all of these patients. Ultimately, they'll be divided into genotype negative and FDG negative patients, all the way up to genotype positive and FDG positive. And we really think that there, is reasonable indication to kind of continue the diagnostic workup even for patients who are genotype positive by potentially doing biopsy on these patients. And we're also going to be acquiring arteriovenous gradients, so blood from the coronary sinus, the radial artery, and the femoral vein, to try to understand what is the difference in metabolite uptake. And this is again referencing this 2020 paper published in Science by a group from Penn, utilizing a very powerful, what we think is a very powerful methodology to look at metabolism within myocardium. And this is actually something Lee Bacchus is doing here as well. So he's helping us with this project as well. But when we take blood samples from the radial artery, femoral vein, and coronary sinus, we can determine what is the uptake of carbon and what is the uptake of energy and what is the energy utilization by muscle bed. And again, this group on the right here is able to actually distill this down into different types of metabolites and the utilization of different types of metabolites by tissue. So we think that this is a powerful methodology that's going to really be able to help us distill sort of what patients with FDG-avidity and without are doing in their myocardium. And so we're going to be increasing enrollment. We're adding a control arm. We've already got 12 patients enrolled with blood from these patients and samples from these patients. And we're going to be doing our metabolomic analysis, hopefully shortly here, to compare patients with and without FDG-avidity and with and without genetic cardiomyopathies. Okay, Talked about a lot there. My mouth is tired, and I'm sure you are tired as well. This is in summary, we sort of talked a little bit about non-ischemic cardiomyopathy. It's a very heterogeneous class of disorders, but frankly, probably we're underdiagnosing both sarcoidosis, and we're probably underdiagnosing genetic cardiomyopathy, and hopefully we can sort of improve our differentiation of types of non-ischemic cardiomyopathy. And we also talked about PET, which is an important tool to understand metabolism in hearts. And while it may indicate differences in inflammation, it could also indicate differences in metabolism. And we found that many patients with genetic cardiomyopathy have positive PETs, which we suspect could be related to a metabolic switch rather than inflammation. And then in order to investigate this further, we've got ongoing research projects to understand the underlying causes of FDG-avidity in genetic cardiomyopathy. And our hope is that by disambiguating types of non-ischemic cardiomyopathy, we can start looking at therapeutic targets in the future. Okay. On the right, that's me, my wife, and my dog. Obviously, I have my wife to thank and my family and everything. I don't really have Angus to thank, but he's there. And for acknowledgements, mentorship from Babak and April has been really helpful, obviously, and instrumental for this project. I want to thank Shinlin again for all the tissue he's collected. Grant Cludd works in April's lab and has been really helpful as well. And then Richard Chang, Rong Tian, Neil Chatterjee, even Bryce added to the list here. Very helpful for sort of coming up with ideas for this project and helping us move forward. I also just want to mention my clinical mentors, David Owens and Yoni Buber, have been very helpful for my career development so far. And then I had to mention Donna Summer, since of course she was the inspiration for this talk. And many references. I'm going to pass around this microphone as needed.
Yeah, so for those in the room, unfortunately, this is the only microphone that we have. So if you guys have questions, please raise your hand and we'll pass it around. But I'm gonna go ahead and get started because we do have some questions online for you, Graham. So first, there's a question from Milish Thompson. It's actually a very good question. So there is an increasing use of PET-specific tracer uptake in terms of advanced PET tracers. Her question is whether if, let's say, you tag free fatty acid and use PET imaging, whether you can differentiate between glucose versus free fatty acid metabolism.
Yeah, it's an amazing question, and one we've kind of wondered ourselves. I don't know that we have the capabilities here at University of Washington to do that currently, but it's definitely something that we've been thinking about and probably will be very helpful in trying to understand this going forward. Yeah.
And then there's a couple questions from David Owens. So David says, great talk. There's definitely a gap in knowledge regarding the cause of FDG-avidity in patients with genetic cardiomyopathy. A couple questions. First, the areas of FDG-avidity are often quite focal, as well as the areas of LGE. These patients often have ongoing detectable elevations in troponin. Do you think this metabolism alone is sufficient to cause cell death? And would it explain the rise in troponin? His second question is, based on your research, which genetic cardiomyopathy patients should we be sending for FDG assessments?
So I guess I'll start with the second question first. I think at this point, it's difficult to know what the utility of FDG PET is in genetic cardiomyopathy. And I think there's some lines of evidence that suggest that it can be helpful prognostically, but it's not clear necessarily that it would sort of influence our management. We're not sure, again, whether or not there is a modifiable change in metabolism or a modifiable sort of inflammatory infiltrate that we can treat at this point. I think that's some of our hope. We hope to sort of sort that a little bit with our retrospective study, as well as looking at mechanisms going forward. I think the second question was, is FDG PET enough to explain cell death? And I'm not sure necessarily that that looking at metabolic changes, these metabolic changes are necessarily the cause of cell death, but maybe kind of co-occurring in the same tissue. I mean, I think There is some evidence to suggest maybe activated fibroblasts are more sort of glucose avid, and therefore FDG-avidity may be looking at scarring that could be co-occurring, or any sort of other process, just sort of sick myocardium in general having changes in metabolism may be what we're highlighting. And so I don't know that it's necessarily picking up the cause, but it could be just co-associating.
Okay, great. It looks like there are some questions in the room. Well, to make this easy, please just come up and speak into mic so we don't have to pass it around.
I'll meet you halfway.
Perfect. Thank you so much, Graham. That was a great talk. You mentioned a couple studies where you were looking at patients with genetic cardiomyopathy and FDG PET avidity. I was wondering if you know when the timing of the PET was, like if it was during an inpatient hospitalization, outpatient hospitalization. It seems like a lot of these sarcoid patients, they have periods where they're inflamed and then not inflamed on PET. Maybe there's something like an acute decompensated heart failure, for example, that would trigger FDG avidity.
Yeah, it's a fantastic question. And actually in our tissue analysis, we're going to be limiting, I think I alluded to this a little bit, we're going to be limiting when that FDG PET could occur. And so those 3 patients that I showed, that I highlighted, that will ultimately be included, the PET occurred like 3 weeks before the transplant. And so that's kind of a more helpful look at what's going on in the actual tissue when it's co-occurring. But yeah, I completely agree. I think you know, it may be possible that if you just sort of looked at a patient with genetic cardiomyopathy over their entire course of illness, that at some point they'll all have positive PETs. I'm curious, yeah, but I also think that it may be highlighting something sort of underlying there, that not every patient would have that, or not every patient would have that metabolic change. So it could be sort of kind of adverse remodeling that we're looking at, or sort of a unique pathology in these patients. So, but I completely agree. I think timing is really critical.
Thank you, Graham. Really impressive body of work and really exciting momentum that you have headed into your EP fellowship years. Just to try to bring it back to the case you started with, to kind of try to tie some things together, you know, in my own mind. So that gentleman ended up having, you know, positive FDG PET, and then had that Titan on genetic testing. So regarding management in that situation, it seemed like Titan was sort of one of the generally less inflammatory, or not quite like Lamin cardiomyopathy in terms of the degree of complications. Do you treat that patient with immunosuppression? Do you not? How do you kind of put these together now in your clinical practice?
Yeah, I think it depends on where you are. I mean, I think if you're receiving care in that group in Italy, you probably would get immunosuppression. I think for now, we don't know. I mean, we never found any inflammatory infiltrate on this patient, even when we utilized a voltage-guided biopsy. And so it's not clear that there is actually active inflammation in this patient. So I don't think we can necessarily treat this. But yeah, and whether or not it has prognostic value for this patient, I think we're going to hopefully distill that out. But as for now, we don't have any specific treatment recommendations. But again, you know, it depends on where you are. I think that group in Italy would have treated this patient.
So we'll use this as the last question here. So there's a question from Rashid. For your biorepository or your biopsies voltage gated, is there any data that random sampling can be predictive of generalized fibrosis and inflammation? So I think the question is, you know, if your samples are voltage gated, and then, for example, whether focal findings are representative of generalized abnormalities, or whether it's not.
Thanks, Rashid. The biopsy samples, so those are actually just from tissue. Those are explanted hearts or LVAD core samples. So no need for voltage guided biopsies in that setting. And from the standpoint of, you know, do those samples correlate with fibrosis? I mean, I think, you know, we know from MRI data that patients who have big areas of scar or LGE, you know, kind of may also have sort of abnormal fibrosis throughout the myocardium. And so it's probably related.
We're going to actually end. That's okay. Great. Thank you, everyone. We're right at 8:30, so we're going to go and end this session. You know, this is such wonderful work, Graham, and we look forward to everything you're going to do with this as you stay with us for EP fellowship. If you guys have other questions, please talk to him after.
Thank you.